Muy buenos días, gracias a la academia. Y el siguiente ponente es una conferencia magistral del doctor Matteo Cesari, que ya está por ahí. Él es un médico geriatra romano que tiene más de 600 publicaciones, que ha trabajado desde Jacksonville, en Florida, para hacer su doctorado, pasando después por la Universidad de Toulouse, Paul Sabatier III, en donde fue jefe de la unidad de investigación, después para regresar a su país, a Italia, en la Universidad de Milán, en el Politécnico de Milán, siendo el líder de la unidad de geriatría también de los hospitales dentro de Milán, y en los últimos años se ha desempeñado como el asesor científico, el científico geriatra gerontológico de la Organización Mundial de la Salud. En la unidad de curso de vida, el doctor Matteo Cesari afortunadamente ha colaborado con nosotros en distintas ocasiones y ha aceptado amablemente, como es él, como es un gran ser humano también, a tener la primera conferencia del día de hoy. Matteo, thank you very much for being here, and please, the floor is yours. Thanks again.
Thank you, María del Carmen, for the introduction. Unfortunately, I do not speak Spanish. I understand Spanish. I'm Italian, so I understand Spanish, but I do not speak Spanish. Thanks a lot for your invitation. I'm very happy to be here with you, and I'm going to present you over the next 45 minutes the United Nations Decade of Healthy Aging. I'm going to share the slides with you. I hope you can see them. So I have no conflict of interest to declare, and let's start with what is the Decade of Healthy Aging. In 2020, the United Nations declared the decade between 2021 and 2030 as the Decade of Healthy Aging. This means the United Nations promoted global collaborations, bringing together all the different sectors and stakeholders. So, I mean, government, civil society, international organizations, of academia, private sector, bring all the stakeholders together for a common objective, a unique objective that is the improvement of promotion of healthy aging. The idea is to generate a unique opportunity for transforming really the world in a radical way in order to allow people to age in a healthier state and reach life to years, not only years to life. The UN Decade of Healthy Aging is strongly rooted on the document that was published in 2015, the World Report on Aging and Health, in which healthy aging was defined for the first time as the process of developing and maintaining the functional ability that enables well-being in older age. Now, in this construct, three different concepts were presented to explain how we age and how we can promote healthy aging. A critical construct is intrinsic capacity. What is the intrinsic capacity? The intrinsic capacity is the composite of all the physical and mental capacities of an individual. It is mainly every capacity under our skin that allows us to live and to function. Our biology, this intrinsic capacity, by interacting with the environment, so the external world, it gives life to the functional ability that combines our capacities, the environment, and the interaction between the two. Functional ability represents our objectives, what is really meaningful for us, what gives dignity to our life. I'm going to present you this concept in a visual way, in a graphical way. So this is the trajectory describing intrinsic capacity. We develop our capacities during the first phase of life. We reach a substantial plateau during the adulthood, and then there is a decline in capacities with aging, and particularly during the last phase of our lives. The blue line describes the trajectory of functional ability. Our values, our priorities, our what we aim to remains relatively stable over life. We have relatively stable objectives to our life, and but as you can see, the two lines, the blue and the red lines, tend to diverge at older age. The gap between our capacities, the red line, and our abilities, what we would like to do, what we can do, has an increased gap represented by the environment. In other words, the environment becomes more burdening over our capacities, precluding very often to express our functions, our abilities at our best. So in the clinical setting, in the care setting, what we can do is to push the red line up by working on our biologies, by reducing the environmental barriers, so to have our capacities meeting as much as possible the blue line of our abilities. And by increasing our capacities through also the action, again, on the environment, we may also set higher standards for ourselves, for guaranteeing quality of life, the growth of the individual, but also for the society, because we live in a world that is globally aging, and for which we need to find solutions. We need to involve more and more people, independently of their age, in the sustainability of our society. Now, aging is a random process. There is no typical older person. And this means that we need to overcome the usual stereotypes brought by chronological age or by diseases. We need to approach, this is what the WHO is saying, we need to approach the older person by looking at the functions, of the capacities, at the different priorities that the older person may have throughout his life. And potentially we need to also include some life course, the appreciation of the life course evolution of the health, the individual's health, because by aging, we also change our vision of the world, we change priorities, we change also needs. The traditional one-fit-all model, typical of the traditional medicine, of the usual medicine, very disease-focused, does not work anymore. We need to have something more dynamic, more flexible, bringing together aspects that today are not adequately considered and may represent the critical issues for the older persons who remain, given their heterogeneity, with many unmet care needs. I'm going to show you, I hope you can see a video. So now, as it was shown in the video, the baseline report of the decade of anti-aging was published in 2020, and as it has been shown, it describes the status of aging across the world at the baseline of the decade of anti-aging. At the end of October, there will be the first interim report that will be published by the WHO, showing the first 3 years of activities that have been conducted within this framework. There will be a second interim report in 2026, and then there will be the final report at the end of the decade. So how we do activity, how our activities are organized under this framework of the decade of anti-aging. There are 4 action areas, there are 4 enablers, but the key aspect is that older persons are at the center of action. And as you will see, older persons are directly involved in all the activities that are under development, that are currently conducted, with a bidirectional exchange that is constantly kept active with older persons, because there is the idea of reshaping, as I was saying, the world in order to improve healthy aging, and the end user has to play a very active role in this. The first action area for the decade of healthy aging, so the first objective for improving our world and make it more age-friendly, is combating aging. This is the first action area. We need to change how we think, feel, and act towards age and aging. In this context, the WHO has published a couple of years ago the Global Report on Aging. Now, ageism has a very clear definition. Ageism refers to how we think, feel, and act towards others or ourselves based on age. Ageism is everywhere. Ageism is a highly prevalent issue in the modern society. It is something that is affecting the life of people, precludes people from interventions in the clinical setting, and substantially decreases the quality of life and the capacities of the individual. Sometimes ageism also interacts with other forms of prejudice or other forms of discrimination, such as related to sex, race, and disability, making it even worse. There are different forms of ageism. Ageism can be institutional, when there are laws, policies, norms that may somehow discriminate persons because of their age. There may be an interpersonal ageism resulting from the interaction between 2 persons. And there is also the self-directed ageism, and we saw a lot of self-directed ageism during the COVID-19 pandemic. For example, when older persons decided not to go to the hospital because they preferred to leave their space, the place, to younger persons. So there might be also a form of self-ageism that has to be considered. How we act against ageism, there are the Global Report on Ageism is the first document published by the WHO, in which it is stressed that we need to act against ageism at 3 different levels. We need to modify policies and laws in order to avoid talking about chronological age for discriminating persons and for generating potential inequalities. We need to act on education, because ageism is fundamentally based on cultural issues, and we need also to promote intergenerational relationships. In a way, there is the need of giving back to those who gave us our life, and our opportunities. So there is the need of generating these bidirectional relationships between younger and older population in order to age as adults. The second action area in the decade of healthy aging is related to age-friendly environments. I presented you before in the framework how environment is a critical action for making our life better. We need a positive environment in order to fully express our capacities and reach our abilities, the objectives of our life. There is the need of ensuring that communities foster the abilities of older persons. And how this can be done? This can be done, of course, by making cities more friendly. When we walk in the streets, when we enter into buildings, we see a lot of environmental barriers. There is the need of modifying the environment where we live in order to make our communities, our environment more age-friendly. And in this document that was published last year, there is a guidance in order to identify which are the indicators for measuring the age-friendliness of a city. There are a list of indicators that are suggested in order to support local efforts at improving the quality of our environment. There is a website available in the WHO webpage that is also gathering the global expression of age-friendliness of cities by reporting many examples from all around the world of cities that environment interventions communities that have accepted to improve in their structures in order to be readier for the aging of their community. Of course, I'm a clinician, I'm a geriatrician. I'm interested also in improving the environment where I work. So starting from the primary healthcare setting, there is the need of revising the environment to make it more age-friendly. One of the issues of older persons when they are admitted to an hospital, to a healthcare setting, is an hostile environment that is not designed for their impaired capacities, for their dysfunctions. It is needed to adapt the environment for providing the correct care. There is the so-called iatrogenic disability that is very related, very strongly related to environmental issues. So what does it mean? This means that if we start having, especially at the primary healthcare level, a more age-friendly environment, there will be a more efficient use of resources. There will be the possibility of better detect clinical issues and promote prevention. There will be the possibility of training also the workforce at the right way to approach older persons. And also medical programs will be seen in a different way. Another action area, and I will spend a little bit more time on the last two action areas. The third action area is the action area about integrated care. So again, just to repeat, the UN Decade of Healthy Aging is based on 4 action areas. These are the strategies for improving the world where we live and allow to have healthy to the life of years of life. Now, in the action area 3, the WHO promotes a better integration of care services. Stress the importance of delivering person-centered integrated care and primary health services responsive to older persons, which is the issue behind the need of acting in this way. We live in a world that is characterized by the disintegration of care. Older persons frequently are burdened by services that do not talk to each other. There is an incredible amount of information that is lost during the care pathway. There is not a continuum of care offered to the older person, frequently suffering from multiple diseases and somehow forced to see multiple doctors and specialists in different settings, in different needs. Very often, older persons may have also difficulties at accessing care services. And I'm not only thinking at the physical access to the building, to the facility, to the physician. It's not only a matter of mobility issue, it's a matter of distances. Many older persons live in rural areas, and the access might be limited because of geographical distances. Bringing integration of care into the field, connecting in a very strong way with the primary healthcare service, may facilitate the continuum of care delivery, but also in an integrated way. It is important to promote an integration of care because having multiple persons around the patient, around the older person, may facilitate exchanges, and in this way also reduce the ageist attitudes that are always present in the clinical care. There might be the possibility of building better interventions, multidisciplinary, multi-component interventions for the benefit of the person and indirectly also for the benefits of the society. And then, which is another issue that is challenging older persons today, is the lack of interventions focused on what really means for an older person. In my clinical practice, I have never had an older person complaining because he doesn't want to die or because he doesn't want a specific disease. The problem of older person is that very often the objectives are not seen by the clinician. Every one of us wants to live more or less, but at the end of the life, he wants to be physically, cognitively, and socially independent. The autonomy of the individual at the end of life is critical. Unfortunately, the evidence is not built for this. The evidence is built for the management of diseases. We are transforming diseases, and there is no attempt to look at which are the values, the priorities of the individual that give dignity to the life. We need to work on this, and by sharing, by integrating services, there is the possibility of including the participant, the patient's voice, into the decision-making process, because at the center of action in an integrated care system, there is always the person. And as I was mentioning before, it is important in this integrated care scenario to have the primary healthcare system strengthened and put at the center of action. This is from a document that was published a few years ago, in which it was stressed the importance of this setting for the universal health coverage, for making the systems sustainable, robust, and in order to indeed promote a preventive approach of care. So there is the need of decentralizing the system from the hospital center model that we live today into the primary health care, because we want to get closer to where the person lives, ages, and eventually will die. In the context of integrated care for older persons, the WHO published in 2017 this document that it is important because it provides evidence-based guidelines for intervening at the community level for managing declines in intrinsic capacity. In other words, in this document, again, based on evidence retrieved from the literature, the WHO indicates 13 different interventions that can be implemented at the primary healthcare level, so by general practitioners, for meeting some critical needs of the older persons. And I'm talking about critical needs because are determined by a loss of intrinsic capacity, by those capacities, physical and mental capacities, that are critical for the healthy aging of the individual. In this document, it is said that we need to, of course, screen the capacities before looking at the diseases. We need to identify which are the capacities that are impaired, and for these impairments, we may start a personalized care plan, of course, taking into account the underlying diseases, but centered on the restoring of the lost capacity. In the same, at the same time, the WHO also developed this document that is entitled Implementation Framework Guidance for Systems and Services, that explains to public health and service managers how to design an integrated care system. In this document, the WHO explains that to accomplish the action area 3, so integrating care services, we need to act at 3 different levels. We need to act at the micro level, so changing the way in which the clinician approaches the older person. So there is the need of shifting from diseases to capacities. We need to act at the meso level, so how the services are structured. So we need also to act on the environment, or on the dynamics within our facilities. And we need a macro level of intervention. That means that we need to act on the policies, on the laws regulating the care system, in order to generate the framework in which integration of care is possible. Following these documents, the WHO also published this handbook in this domain. This is a guidance, this is a sort of cookbook, I would say, for clinicians, for the health and care workers operating in primary care. Again, the primary healthcare setting is critical for the implementation of the action areas in the decade of healthy aging. And here is a guidance for explaining, for describing, for training the care professions, the care workers working in this setting on how to approach to the older person, how to screen the complexity of the individual by looking at the different domains constituting the intrinsic capacity. So how to measure mobility, malnutrition, visual impairment, how to measure hearing loss, the cognitive decline, how to detect whether there are depressive symptoms, in order to develop a personalized care plan close to where the person lives. In this document, the WHO presents a screening tool, very simple. In many countries, this tool is not even administered by a nurse or by a clinician, by a social worker, by a technician who has just to go through the different questions, identifying the weaknesses and impairments that the person in the community may present. In case a certain impairment is identified in this step 1 screening phase, then there is the activation of the so-called step 2, that is focused to an in-depth assessment of the individual, understanding the level of weaknesses in the different capacities, of course assessing and managing the underlying diseases, but also taking into account the physical and social environment where the person lives. With all the information gathered during this comprehensive evaluation of the individual, it will then be possible to develop a personalized care plan with eventual referral to specialists and to other services with a monitoring care plan put in place. And last but not least, also the involvement of the caregivers, eventually also supporting the caregivers, because in an older person we have to look at the dear patient caregiver in order to deliver a personalized and robust care plan. This model of care has been implemented and piloted in different studies across the world. The results of these pilot studies was published last year in this document that is showing how systems are not all ready for the implementation of this integrated care system. There are countries, of course, high-income countries are better prepared than low-income countries in adopting and implementing this new way of working, focus on capacities, on abilities rather than on diseases. But interestingly, in this document it is well described how the health and care workers, how patients themselves are very happy about the new way of conducting clinical practice in this framework, because it is more centered on the person, provides more benefit to the individual, and is also targeting what is really important and felt critical for the person. The action area 4 is about long-term care. So, ageism, environment, integration of care, but we also need to work on the care systems in order to give access to care over time, over the long term, when the person needs it. Please, when I talk about long-term care, when the WHO talks about long-term care, do not think about the facility, do not think about the nursing home, but think at the provision of care over the long term, because there are conditions who may need continuous care over time. Consider that there are countries around the world in which the long-term care facility, as we have in our mind, the nursing home, do not exist. In the long-term care, as the WHO is framing, we have rehabilitations, we have care on care services, we have, of course, long-term care facilities as nursing homes, but we also have palliative care, and every care that is designed to be provided over time. Which is the vision of the WHO in this setting? Again, services are person-centered and are coordinated. Here, older persons and carers have to receive, have to have their dignity and autonomy preserved as much as possible by integrating the continuum of care according to the specific needs they present. Of course, the accessibility and the affordability of the system is critical. There are discussions about how to fund this framework, but of course, the idea is to have something that will not burden the financial status of the individual. As for the action area 3, there are strong discussions about the importance of promoting multidisciplinarity and the intersectorial action to promote long-term care. We need to develop an approach, a care approach that is not anymore vertical, but cross-sectional, involving different actors positioned at the same level. We know very well which are the issues in this vision. The governance is complex, uncoordinated, and fragmented. Very often we do not talk anymore with the Ministry of Health, but there are ministries of social affairs involved in the management of long-term care, of nursing homes, or specific services. So there are two actors at the national level who might be involved in the delivery of these services. of course, generating redundancies, potentially wasting of resources, and there will be also misunderstanding and ambiguities. There is not sufficient investment in this field. That's always been seen as a lost case. I mean, something in which there is no appeal in going to working, and there is the need of training, not only for the care workers, but training also for the many informal caregivers and paid carers who are taking care of older persons. Very often these caregivers are women, are persons without formal training, with low education, that may require support in order to create an environment that is sustainable over time. In this context, under this action area 4, the WHO published a framework for countries on how to achieve the integrated continuum of long-term care. And as you can see from this slide, we have at the top the intrinsic capacity and the functional ability. Their trajectories diverging over time, but at the bottom of this graph, we also have all the different services that we have available, and we need to consider them as potentially possible to activate according to the evolution of the individual, according to the specific changing into of their needs and priorities. As you can see in this same document, there are guiding principles and critical aspects to consider. The outcome is always the optimization of functional ability. We do not talk about management of diseases. We talk about the abilities that we need to guarantee to the older person as much as possible. There is the need of a government in this coordination of care services, in this multidisciplinary environment. As you can see here, we talk about equity, we talk about human rights, about person-centered, and there is the need of a leadership that very often today is lacking, again, because these are services that very often are abandoned and for which investments are relatively low. I mentioned at the very beginning that there are 4 different enablers in the decade of healthy aging, 4 aspects that have been identified as critical for achieving, successfully achieving the 4 action areas. The first enabler is to listen to the older persons. So there are every document, every intervention that is proposed by the WHO sees the meaningful engagement of older persons in the development of the documents, and the older persons play a critical role in the definition of the strategies under this framework of the decade of healthy aging. Another enabler is the building of capacities, is the training of the care workforce, of the leadership, in order to promote correct action across sectors. There is the need of connecting stakeholders around the world, so there is the need of sharing experiences, and I will show you an example. And then there is the last point, the last enabler, the last facilitator, that is represented by research. We need research in order to strengthen our actions and our data. Again, it is not easy to work in the reorientation of care services having a background literature that is specifically focused on diseases. We need to generate a body of evidence that is touching the clear needs of the older persons that are based on capacities and functions. I was talking about the training. Now the WHO is training the health and care workers around the world about the integrated care for older persons approach, about long-term care. These are examples from Kuwait, and for Botswana. two countries that are very different, different problems, different objectives, different resources, different cultural backgrounds. So in the activities of the WHO, there is the need of presenting a global approach, a global standard, but then there is also the need of accepting an adaptation of all the interventions, of all the actions according to the local needs in order to promote the feasibility and sustainability of the interventions. So the actions remain the same, but in the implementation in the clinical practice, there might be adaptations also to benefit from the existing experiences and existing activities. This is what I was mentioning before, a platform that is available in the WHO website, where we can share experiences about our programs, about our initiatives focused on promoting healthy aging. Many of the activities that have been uploaded and described in this platform have become part of the progress report, of the interim progress report that will be published at the end of October, the report that I was mentioning you before. It is a matter of putting together the experiences for building the new world, for sharing experiences, and for seeing how others are acting for the same objective. And this is my last slide. It is mainly for supporting the fourth enabler of the decade of healthy aging. It was about research. Now, a question that I frequently receive from researchers from the academia is, we have been working on frailty up to now, and we have convinced the governments, the public health authorities, are investing on this topic because our geriatric expertise, the evidence was telling us that frailty is a critical condition to tackle. There is the need of multidisciplinary action, of reorienting services for meeting the needs of the older person. Now the WHO comes out with a new framework. But what about all the activities, the evidence that we have been building up to now? Well, it is experience. This is part of the data that we need, is what has helped the WHO building this new framework. This is an example of a study that has been published online a few weeks ago, in which it is shown how the experience coming from a frailty clinic, from an intervention aimed at the management of frail older persons in the community, was able to support activities also for the WHO, generating data of interest for the WHO, because the core of elements of information that was collected there is shared with the new framework. There is the opportunity so to give value to data that were collected for other reasons, for other objectives, in order to build the data on which develop future actions. Again, we need to give value to what we have. We need to reorient, not reinvent, and we need to support this transition in the approach to older person as much as possible. Thank you.